tomorrow, basically. So I think this is a fundamental part of you could say the contract of trust around collecting health data without consent.
Okay, so we've got some interesting sort of parameters here. There's links to sort of computing, the continued investments and continuous updating of infrastructures to harness the volumes of real-world data, also coming from E&M health and wearable devices. We have the patient-centric approaches, more transparent outcomes, the possibility of having far richer, more transparent individual patient data records that also includes the outcomes of treatment, more of an ecosystem approach linking health into ID, into education, into industry, and so forth. So, you know, all of these are wonderful, but then we need to think about some practical next steps, which can either be taken at the level of organizations or institutions or even international bodies. If we want to accelerate the shift towards this, this development of real-world evidence and a more connected, effective use of health registries and health data, real-time, real-world flows, what would you need from public agencies? What would you need from industry? What would you need from scientific communities to unblock next steps or to unlock the potential to move forward? What would you really like to see at a political level or a scientific level or even from an enterprise level?
I think if at least from where I'm sitting right now, one of the areas that have our focus is of course new technologies for secure handling and sharing of data anonymized. There is this right now of talk about using synthesized data sets and so on. These kinds of you can say technologies from the industry can enable us as a health data provider and enable us to provide data in new ways for more different kinds of organizations. So that could be at least one perspective, is of course that if the technology can actually help us maintaining the privacy and security of our citizens at the same time as we use our data, I think a lot of this discussion we have right now with consent, with the GDPR and so on, we could maybe have another approach or another insight into this discussion. So at least that could be a wishful thinking for the future from my perspective. From a more political side, I think in Denmark we often look for what you could say a gradual approach. If you look at the European health data space, there's a big vision. It's all encompassing, and I think if we just go forward for this strategy, we will hit so many areas of troubles and difficulties that we maybe will just go to a full stop. So I think we should try to look for the quick wins, look for the small solutions, and build from there. Maybe a bit more bottom-up approach, I would say. That could also be at least from our perspective.
Yeah. So let me float something else, and actually, Arild, this came up in our Trondheim roundtable a year ago as well, which is the difficulty of startups in particular to get access to clinical settings to prove whether or not your mHealth solutions work, right? And so in many ways it was the fundamental tension is that they run out of cash before they get the data.
Yeah.
If we're talking about, again, you know, a more integrated, connected system of health solutions, so then driving, you know, a better collation and integration of real-world data, is this a really important step to take as well, that we need to pay attention to how we can connect innovation to clinical and understand what really works?
Yeah, I mean, the first thing you need to have is a shared vision. or where we want to go. And I think we are heading towards that. When it comes to mHealth innovators, I think we are not that far away from having a clinical trial recruitment functionality in the national eHealth portal, and as such, an ecosystem for reaching out to patients within the patient-centered national portal. So I think this is also a question about having a shared vision, knowing how to get there, and building the infrastructure. And when it comes to assessment of mHealth and eHealth technologies, it is also a question of competences and skills. And as a university researcher and teacher, we also work with building those competencies, that next generation of healthcare workers that have became healthcare workers when interacting with modern eHealth systems. And because of all this data that we now get from all these systems and tools, we need healthcare workers with slightly different skills, and we need people that can work at the intersection between technology and organization, and technology and data. And those people we want to educate.
Yeah, that's one red thread that's come up in pretty much every single Healthy Measures meeting that we've organized in the past 4 years, sorry. This question of capacity and skills, and I don't think we have a solid answer for that yet. But perhaps moving slightly on, and there's a really good comment from the room here around sort of quality control and validation of health IT solutions. I mean, there's a great example in the UK which links these 2 points. I think the NHS has basically put in place a platform for E&M health solutions, which will then be sort of reimbursed for 12 to 18 months. And also there's an independent panel that assesses feasibility, quality of data, and so forth. So if that's one model of sort of encouraging the grassroots innovation, then the question also becomes, what do we do with the data? Is it a condition for supporting innovation and startups that the data becomes publicly available, for example? Would that fit with the Danish ethos, for example, Hans? Would it be complementary with your current data structures and registries?
I think not entirely. If you go, for example, to the Danish Federation of Industry, they would tell you that there is too big a threshold, as you just said, for small companies to access health data. I think we have what we could call a research-heavy model right now. So you have to be an official research institution to access our health data, because our health data is on an individual level. And so we do still not have, I think, all the answers as how we unlock the potential of innovation from all these small companies with the regulation and with the privacy requirements of our health data. I think one of the things, as I said before, is that we are hoping that new solutions for you could say data security and using synthesized data and so on maybe could be a part of the solution to these problems that would enable a better access for data, for example. But I think in Denmark we are still, I think, searching for the solutions. We are not there fully yet. I think another way of looking at it at the hospital level, we have these innovation labs and innovation centers that collaborates locally with healthcare providers developing new tools. I think this is a different approach. Instead of going to the national agency with all the health data, you can also go locally and to a health innovation lab and make collaboration with a specific hospital, for example. That could be a different model, and we see this growing right now in Denmark. In part based on experiences from Israel and other countries that has these innovation labs.
Okay, that's very useful. Now I'm aware that we're sort of indicatively at the end of the program time, but due to the IT hiccup, I hope people will stay with us for another 5 minutes just to answer a couple more questions. There's a broader point about the role of the public in helping to design or at least be an active voice in the discussions about what the future of smart connected health looks like, the use of patient data. That's fine at an individual level, I think, but is there a role for a more engaged public debate, public consultations on future use of health data, or is it unrealistic to expect those to take place? Does this need to be a more of a top-down approach that then is picked up at the level of the individual patient in terms of clinical application or use of apps or data ownership and privacy?
I think in Norway, we heard about the European Medicines Agency and the principle of patient-centeredness there, which is they were pioneers, and that model has been implemented in Norway as well. We are the engagement of patients is mandatory in research projects in Norway, and we have to explain how we do it, and we have to and patients are also engaged in developing a more on the research policy level. They have consultations with the patients. So I would say in Norway, this principle has been implemented already. Of course, the patients will have a lot to say when it comes to mHealth. But the comment from me on that is that, we heard about personalized medicine, and that is a very big topic, that you adapt the medicines to the individual. But mHealth and eHealth solutions is very much about personalizing healthcare system. It's about adapting the healthcare system to each individual patient. And when it comes to one particular mHealth solution, it doesn't fit all patients. Some will have low health literacy and e-health literacy, and they will have to be taken care of by traditional means. But for those most literate and competent patients, mHealth can be used to automate the services so that resources can be cleared to be used on the more demanding patients. So I will say that one of the problems with mHealth is that, yes, it's towards individual patients, but actually it is a healthcare system intervention. And that has implications for evaluation as well.
Mm. Excellent, thank you, Arild. Okay, all right, listen, I'd just like to put two more sort of questions in, and they're kind of related, and it's a bridge into our discussions this afternoon, which are going to look a lot more at artificial intelligence, data strategy, and so forth. So I guess there's possibly one here for each of you. The first is whether current data registries are limited because they don't yet contain the vast sets generated by, well, predominantly American-based tech giants, but I guess also the Chinese. So is there already a boundary of limitation that we have a volume of data, but it's too fragmented and distributed? And does that in any way limit the efficiency with which we're using registries? So that's question number one. And then the second is a link to AI and the ecosystem around patients. And the question is whether you think that our networks, data, the e-infrastructures and so on are sufficiently developed at the moment to support large-scale use of AI or similar technologies in the future patient journey, right, and the future portfolio of services that are made available. So let's see, who goes first? Maybe Arild, do you want to take a stab at the AI one first, and then Hans will?
Yeah, my stab at the AI is that we have this explosion in data, not only when it comes to mHealth, but also when it comes to within the traditional healthcare system. We have this explosion of data, and we have these health problems that are beyond the scope of human computation. And that is the perfect domain for AI-based solutions. And I think AI will become a tool just as the stethoscope and the laryngoscope for the future healthcare worker. It's just a question of building the tools and building the competence and integrating the services with the rest of the things we do within healthcare systems. And of course, we have these large old data sets. They are a legacy. They might be a problem, but it is also an opportunity because they have very high quality. And if we make good choices, we can build something better and stronger if we combine what we have with new data from mHealth. And that is the way forward.
Going hand in hand, of course, with the ongoing investments in the infrastructure and computing and so forth required to deliver that. And I guess also the network technologies, which is another critical part of this. All right, well, listen, Hans, you're going to get the last answer or the last input here. This question about data size within registries and whether that constitutes a limitation. How do you see that?
I think Arild mentioned it quite clearly that these vast amounts of data that we are able to generate now, outside of the registries, of course, is the domain of the AI, where we can really use and utilize our AI. I think, as Arild said, that we should be able to combine the good quality data from our registries, from the history, with the new kinds of data sets. So on the question on a limitation, I think we will not be using the full potential of our AI technologies only using the registries. I think normal statistic methods are fairly good also at deriving knowledge out of our registries. So I agree that if we want to have the full potential and the full insights, we should work towards a combination of the two. You could say the old and the new kinds of data. So in some ways there are limitations in my perspective, but there are also possibilities. And I think if you look at in Denmark right now, we have a strategy for AI, a national strategy, and we have different kinds of signature projects that should give us experience in using technology. And one of the prerequisites is finding an area which has enough, you could say, quality data that we are able to use AI in the first place. So it's not either or. So I think we should use the old data, which might say as the starting point, as the foundation, and then building onwards and utilizing all these vast amounts of new data that we cannot cope and analyze manually as human beings.
Very good. What a wonderful way to wrap things up. It's really been a fascinating discussion and one that obviously is going to continue for the next few years as some of the key components, the pillars of various European flagship initiatives start to materialize, whether it's the health data space, the European approach to AI, this industrial strategy predicated on federation of European data, B2B sharing, public-private collaborations. Is really a case of watch this space. But for now, I would very much like to thank, first of all, Arild and also Hans for taking the time today. Arild, it looks as though you're in the hospital. So yeah. An even more important use of time, with all due respect to Hans. But we really appreciate your openness and all of the perspectives that you've shared with us. The same applies to you, the actually close to 250 people who've been following this conversation and all of the contributions that you've made, the questions that you've asked via the chat function. As indicated, we're going to try and take all of this content, the conversations, the written inputs, and come up with a more holistic view of real-world data and changing the status quo in health. And we will obviously keep you updated when we have a little report or article or something similar to share with you all on the back of this. So for now, I will bring this set of conversations to a close and gently remind you that we reconvene at 2 o'clock with Commissioner Gabriel in the other main plenary room. So thank you again for your time and for joining this conversation. Stay well, good luck with your future endeavors, Arild and Hans, and we look forward to staying in touch. Thank you.
Bye.
And goodbye for
Thanks,
now.
Simon. Bye.
Bye-bye.